Well, I'm glad you are all here again with us this afternoon. We have a busy afternoon. We're going to have 3 panels that are virtually going to go back to back, so get your seatbelts on. We're going to move very quickly. Now, I think one thing is safe to say. This is a very distinguished group before us, members of the Institute of Medicine, and I would say that while each of you have tremendous qualifications, virtually none of you are qualified to be on this panel. This is a panel about those who are going to be inheriting the work that many of you have done and who are going to be part of the workforce moving forward, and it's so important for us to hear their perspective. And I think that makes it even more exciting to have Terry Fulmer, who's going to be leading this panel as a, if you will, newly minted dean and professor at the Bouve School of the Health Sciences at Northeastern University, where she's also a professor of public policy and urban affairs. She is a member of the Institute of Medicine. She is a highly regarded expert in geriatrics, which makes her very suitable to deal with newly minted professionals. So Terry, take it away, and you're going to introduce your panel.
Thank you, and thank you all for being here and listening to what I know will be an even more rich discussion building on the conversations we've already had today. And so we now have the opportunity to build on those exceptional discussions and really welcome our next panel, the newly minted professionals. And we've heard the disconnect today between education and practice. We've heard that faculty are unprepared to lead change. That's kind of scary. A need for a revolution in teaching strategies. We heard about MOOCs and virtual and the future. And yet, the entrenchment of higher education and the lack of accountability in universities and higher ed as the next frontier to find and extinguish waste is right in front of us. And so I think that we'll learn a lot from the individuals on this panel. And in the next 30 minutes, they will really inform us about what we can do better. So I have the opportunity to now introduce them. And it's a pleasure first to introduce each of them. To my left is Dr. Jason Farley, who is a Ph.D. MPH CRNP, assistant professor, Johns Hopkins University School of Nursing, and a nurse practitioner since 2003 in the Division of Infectious Diseases in the Hopkins School of Medicine's AIDS Service. His research focuses on HIV and the epidemiology, prevention, and management of associated drug-resistant infections. He was recently named one of the co-directors of the clinical core within the Hopkins Center for AIDS Research and a co-chair of the Global Health Committee of the Association of Nurses in AIDS Care, and was recently selected by the membership to serve as a director at large within the board of directors of that organization. To his left, we have Dr. Christa Rocco, DPT, received her doctorate degree in physical therapy from Northeastern University in May 2011. Christa graduated on the dean's list of one of the university's 100 most influential seniors. She received the Mary Florence Stanton Award for Compassionate Care and Volunteering, as well as the Outstanding Co-op Award for Excellence in Scholarship. We're glad she's here today. She's currently at the Spaulding Rehabilitation Hospital in Boston, where she's a physical therapist on a split unit for general rehabilitation and traumatic brain injury. To her left, Dr. Adam Schickedanz is a senior resident at the Department of Pediatrics at the University of California, San Francisco. He graduated with honors from the UCSF School of Medicine and Washington University in St. Louis. And he was the Mirzan Science and Technology Policy Fellow at the Institute of Medicine in 2009. As a fellow, he worked closely with the Institute's Board of Healthcare Services staff on studying activities, including the Committee on Planning and Continuing Healthcare Professional Education. So he'll have some good ideas for us from that. So without further ado, let me also just add one point. In 2013, he'll be chief resident in pediatrics at UCSF. So just your run-of-the-mill student group here. We're delighted to have them, and I thought we would start off our conversation really asking them a general question and then move to some specifics. And one might be the obvious, and that is, as you were educated, what were some of the things that you'd like to tell your faculty and suggest on behalf of your peers of things that you might have missed, things that you'd like to talk about now?
So as Dr. Fulmer said, I'm a nurse practitioner and been practicing for many years. I am a newly minted, doctorally prepared nurse practitioner with a Ph.D. Focusing in drug-resistant infections in patients with HIV. And I think my perspective will be from the transition from clinician to researcher. And I think the doctorally prepared nurse, and when I say that, I mean a nurse, whether it's a research doctorate or a clinical practice doctorate, has the following three things that are essential. The first, I think, is preparation and transformative models of education. We've talked a lot about transformative healthcare and transformative models of care, and yet we must prepare faculty in ways of educating in this model or in this approach. This is not a paradigm that we've received much instruction upon. Second, I think cross-training in public health. The slide that we saw earlier today showed us 4 different silos in nursing, medicine, public health, and others were in that silo. I see those silos differently. Nursing, medicine, public health. I see the one bridging degree, the degree where you sit around in the classroom and everyone sitting around you is of a different clinical background or preparation, is public health. The one thing that bridges us all together is public health, and how we integrate and interdigitate public health throughout the curricula, I think, is important. And then finally, the transition from clinician to academician. I think there is a transition there. You go from kind of an expert to novice again, and that novice to expert kind of transition period. And understanding solutions to balance the tenure track and maintaining a clinical focus is important.
Those are great points. And who'd like to add in there?
Sure. So to answer the question that we've been asked, I wanted to really direct it with one specific area, and kind of the topic that I thought about was really prevention. That prevention is a very widely discussed topic for changing healthcare. However, I don't see it being integrated and implemented into the practice of health professionals on a daily basis. If we incorporate it more, we're able to promote better, more healthy lifestyles for our patients, as well as reduce healthcare costs. From a physical therapist perspective, having more education on how to incorporate weight management, smoking cessation, management for diabetes into our education would be able to help us use that in a daily treatment session with our patients. I work in an acute rehab setting, so on a specific basis for that setting, it's, how can each of the team members incorporate prevention into our treatment for our patients, for example, with a traumatic brain injury? How can we focus, even though our focus of our treatment is on the primary deficits that arise from the traumatic brain injury, how can we still incorporate prevention into our practice?
Those are great points. And Adam, did you want to build on that?
Absolutely. I mean, I'd like to echo all the points that have been made so far. I think it's worth acknowledging that there are a lot of good things that are happening in medical education right now, and we don't want to lose those, but we can do a lot better too. And I think this morning's discussion provided a lot of fantastic groundwork and ideas that we can build on and take back to our institutions to begin to implement. So I think my disclosure is really that, I'm a product of this medical system, as well as someone who has a vantage point on it and would like to see a few things changed. So I certainly have the blind spots that a lot of trainees have coming out of practice. So feel free to take my comments with that grain of salt and use me as a foil for the problems with the system, as well as maybe an opportunity to add a few fresh thoughts. The 3 things that I'd like to comment on are these, and these are things that I'd like to see added to our training. The first is really honest-to-goodness engagement in community. We need to understand health where patients live, work, and play if we're ever going to hope to make an impact that really is significant in terms of the well-being of our patients. Getting out of the hospital more is an important first step in that direction. Getting into the clinics more, and also getting out into primary care, community health centers, to learn a few more vantage points on the system and sort of understand the system as a whole. It's critical. The next point that I'd make is that we need to get down to the brass tacks and start doing the hard work of really training in teams. We have a lot of fantastic background. We have a lot of excellent thought and guidelines for how to make that happen. It's really just a matter of implementing it. And I'd love to see that continue over the next few decades as we move forward. And then the last point that I'd like to make to start is really a sort of invitation to enlist us as trainees in the process of changing the healthcare system. You know, we come into the system with a lot of fresh perspective, a lot of energy, and a real vested interest in making the system better because we're about to inherit it. And so we can be excellent change agents if we're guided appropriately and given the appropriate foundation to contribute in a meaningful way. So think of us as allies in this process and see if we can give back before we've even got the degree.
I love that point, and you know, you have a perfect segue there to talk about teams. I heard you touch on it, and let's talk about that. This morning we heard people talk about the need for teams, and we do know that nobody yet has really cracked the code on the right dose of team, the right membership, when, how, and I know that there are a lot of wonderful foundations working on it, but let's pick up the notion of team and what you learned in school and what you wish you'd had, any of you?
Sure.
Oh, go ahead.
You can go ahead.
Okay, I will. Thanks. So what we get in school is minimal. From my experience, it's really the experience that we have as medical trainees once we hit the wards, hit the clinics. We're expected to work in teams, but we don't necessarily have the tools to do that. And so I think we should be finding ways to better deliver the groundwork, the framework for that earlier in training. We were talking over lunch, in fact, about making sure that it's not just sitting in a classroom together, watching a lecture, it's actually laying the clinical foundations together and learning the clinical medicine together that's going to get us to where we need to go.
I don't think that I was truly introduced to the type of teamwork that needs to happen within healthcare until I started my first job. On a daily basis, we meet in interdisciplinary teams to talk about our patients and to really focus in on our patients' care. There's more than 6 different team members that are present in these meetings between the doctors, the nurses, and the other therapists, myself, the occupational therapist and speech therapist, and we're all there discussing how to better provide care for our patients. But in school, we weren't really taught, how to incorporate how to incorporate the disciplines. On a general basis, what each discipline does, but when you're actually working with them on a daily basis, how can you use their time effectively and efficiently? If you have questions or you need to approach a certain professional, who is it that you go to for this specific problems? And a better education model to deal with that would be very beneficial.
Good points.
I think the use of technology has made the potential for training in interdisciplinary teams much greater. The use of simulation labs, so doctors, nurses, and other professionals can practice their first code in a mannequin-type scenario, in a simulation scenario, but practice it together in the roles and the functions of what individuals do. There are lots of algorithm-based decision-making trainings today. The Department of Health and Human Services has a training for infection control that's interprofessional, and depending on your choices, you play a different member of the healthcare team. So if I'm a nurse, I play a physician. If I'm a physician, I play a nurse. And as you go through the scenario and your choices are played out, you will either kill your patient or make them better. And hopefully the latter. But I think more interdigitation in the classroom and the label of interprofessional education, you can't slap that label on, to reiterate what Adam said, you can't slap that label on a course simply because people are sitting in the classroom together at the same time listening to the same person lecture.
Mm-hmm.
So that's a perfect way to then also think about teams and shifting to the notion of community and globality. So we talked a little bit this morning about the needs of a global network society. And so did you learn about that in your curricula?
Yes, I had a very special part of my education at Northeastern where I was able to go work at a children's hospital in Kathmandu, Nepal. I was one of 4 out of my 100 graduating doctoral students that I graduated with that had the opportunity to go abroad during their schooling to use their education in a global way. Unfortunately, I don't think it's as widely used as a way to promote our education. I think from having global experience, you're really taught how to think outside the box. You learn to work with limited resources and how to provide care to a wider community base. These are all things that I can now use on my home from back, working at Spaulding Rehab now, but it made me a better clinician having that exposure, and I think that it's something that that universities need to definitely take a bigger piece and incorporate that into our education more.
Did you have that, Adam?
Did we? We had some. I don't think we had enough. That's my bias, obviously, but I think that might be shared by a number of other people in the room. And, what I think we need to move towards is a greater understanding of how the system works as a whole, and the only way to get there is to train us in various settings with different vantage points and different perspectives on that system. And really that builds towards a higher level understanding of how the system functions, which is really essential in order to move towards making us capable of changing it, capable of understanding all the various pieces that are working simultaneously. And I think it's also important moving sort of up the levels of healthcare intervention solutions. Knowing the system as a whole facilitates understanding the policy levels, the community levels, the social levels, society levels that are all interconnected through the work that we do. And without understanding the system as a whole, I don't think that we can get to that level of the higher level understandings, which is really crucial. Because we do have a social contract. It's not often reiterated in training, which is unfortunate. But if we had the opportunity to think outside of the settings where we're typically trained, the acute care, sick care settings, and focus more on actual healthcare training, I think that would be accompanied by a shift in perspective that would be very useful.
And I know that you've had some global networking, Jason, I think.
Yes, I think doctoral students, nursing doctoral students have an opportunity to explore topics from the bench to the bedside to Burma. And I think everything kind of in between. And I think our challenge really remains finding opportunities for funding for doctoral research in nursing, particularly as it relates to global health. And I do define global health as inclusive of the Baltimore community versus, the international community. It's all encompassing. But I think some of the things that are important, that where my training was probably lacking and that I now see was important in terms of global community and both in practice and in research, is in health economics, health politics, and health policy, and how all three are interwoven in a way that is important for the clinician researcher to understand.
Mm-hmm. So you're moving right into the cost question, which we heard about this morning, and just to roll back to something really important you said, globality doesn't necessarily mean that you get on a plane.
Right.
It's the communities in which we work, and so that sensitivity to the cultural nuances of the people we care for, was that covered in your curriculum?
I would say from a nursing perspective, cultural sensitivity is something that's drilled into us from day one. I don't say that that's lacking from a nursing perspective. I do see an increasing desire of our student population to be globally involved. And by that, I do mean a desire to really be engaged in clinical and research opportunities in the global arena. And I've had students say to me, I have no interest in working in an acute care setting. My interest lies in community public health and clinical practice as it interdigitates with community public health. Don't send me to the hospital. And I think that's a growing call among our students who come into our schools and into our locales. And we have to redirect them and say, no, this isn't a black box, that the community and the hospital are interdigitated in and of themselves, and they work intertwined. So I think that's an interesting phenomenon happening among students these days.
So Christa, what classes or experiences or co-ops did you have that focus on cost and how we manage our scarce resources in healthcare practice?
You know,
You can say none.
No, of course. I would actually say that my co-ops helped the most, in all honesty. Northeastern University is very well known for its co-op education program that you participate in at least 2 different co-ops, which are paid internship, almost always paid internships within your field that you're studying, and you try to use them as a way to gain exposure into your field that you're going into. I did one at Boston Medical Center in Boston in the acute care setting, and being in such an urban hospital was actually a great way to gain exposure to the rising issues of healthcare costs. You know, you've got these patients that I think that, you know, are constantly being readmitted, that, you know, you see them once a month and they're coming constantly back and forth from the acute care setting, and that, you know, you need to find ways to prevent that from happening. And then, as I mentioned earlier, when I went, my second co-op was in Kathmandu, Nepal, where I worked at a children's hospital, and then going to another area where, you know, costs are, you know, at a much more minimum, you know, in a third world country where you don't really have the resources. So, in all honesty, I think it was my actual exposure to these areas that really gave me a better picture of, you know, where healthcare costs are and what we need to do to
Did you
reduce
have
them.
a health economics class, Adam? Or?
We had a few lectures in the preclinical years during medical school, and some of those were actually taught by members of the audience here, but I can remember each and every one, and I could probably count them on 2 hands. But I think where our real education is around healthcare costs in medical training is, as Christa alluded to, is in the clinical setting. That's where the rubber hits the road and where we learn our practice. And you know, that's often very divorced from thinking about health economics and healthcare costs, and that's a problem. I would love to see medical education take this issue on head-on, given the crisis that we have around healthcare costs in this country. It's really one of the most pressing issues that we have as a field. And ignoring the problem and hoping for the best as we now do is really just not going to bend the cost curve. But if there was a collective action on the part of medical educators, we might be able to make a dent, I think. You know, speaking from personal experience, I think understanding the incentive structures that were the underpinnings of a lot of the practices that we have in training, that was revelatory every single time. I understood how the money was moving, what the conflicts of interest might be. That added to my understanding in a way that was really useful. And I think that's the case for other trainees that I've met and talked with. And it really is important because so much of what we do in medicine is not necessarily evidence-based. It's often by convention. And so giving trainees that background helps them sort of parse high-quality care, truly high-quality care that's evidence-based from financially motivated convention. So we have a lot of work to do there. I would love to see medical education take value as a guiding principle that the field would teach to trainees in the future.
Just as a follow-up, as a chief resident, what are you going to do?
Yeah, so I'm actually talking with a number of people at UCSF about trying to integrate the ranges of price, ranges of cost for medical services and tests into the medical records so that when we're ordering these tests, when we're using these tests, we're seeing the costs right in front of us and can do a bit more of head-to-head comparison. I'd love to see that happen. I think there are a lot of barriers to making that happen, but things along those lines are what I'd like to pursue.
So good dashboards. Jason, you're an academic nurse and you're teaching students. Mm-hmm. What are you teaching them about cost and careful economics?
The big discussion today in academic settings, I think, is the tight funding climate for research. I think how to manage resources in a fiscally constrained environment is something that I feel is exceptionally important. I think that you know, cost is the key driving force for healthcare reform. So the patient-centered medical home is something that we obviously pay close attention to in our discussions, and I think that is going to leverage opportunities that are yet unforeseen in terms of potential for interprofessional education, potential for bringing together groups like us, and in a classroom clinical combined setting to really help us facilitate the next generation of clinical care.
Are any of you involved in the IHI Open School? And so there's some nods, and have you been introduced to IPEC, those documents about interprofessional education competencies? So we're making progress. I'll take that as progress. Okay, good. So one of the things that gets discussed is this whole construct of work-life balance. I'm not sure that I know what it is, but people talk about it. And so work-life balance, resilience, when there can be tension and tense times in your practice. And so what did you learn in school that got you ready for some of those moments? And what are some of the ideas you have for the educators in the room and how they might do a better job addressing that? And Jason, why don't you start?
Sure. I think the quintessentially most important variable in the success of a young academician is mentorship. The ability of a mentor to provide and to guide and to basically support a junior faculty member through that process is absolutely essential. I think in very...
Did you have it?
One of my mentors, Martha Hill, is sitting right here in the audience, and without her, I wouldn't be here today, in more ways than one. I think, you know, taking the topic of leadership, we're expected to, in some way, as young academicians, osmose leadership skills. We're supposed to be able to just look at what we identify as strong and appropriate leaders and be able to emulate those activities. And I think truly transformative leadership, as in transformative education, is something you practice and you learn. And I think doctoral programs at both the research and the clinical practice level really needs to provide students the opportunity to practice leadership at an earlier stage in career, not throw the assistant professor out into the lion's den and say, go lead, and expect them to have just learned by watching all those years.
How about you, Christa?
You know, in school, I don't think that there was very much focus on the work-life balance. I don't think that we're taught, that you need to keep that balance. I think you don't really gain that until you actually go into the workforce and you're realizing how many hours you're actually working, and when you get home at the end of the day that you do not have energy to do anything else. And I think that it is something that really needs to be incorporated into education, especially in healthcare. I mean, we as healthcare providers, we're caring for others. We're half the time, we want to take that extra step and do as much as we can for our patients. But when you do that, you're going to be working 12+ hour days, and that takes a toll. And there's not a lot that we're taught how to still provide the best possible care that we can while taking into account that we have a life outside of work. I do think what Jason mentioned about a mentorship program, I think that is something that's really needed. If we had something that started prior to graduating, that you started with a mentor and your last year of school, and it started, it continued in through the year, 2 years of your starting to work, I think that would really help you develop leadership. It would help you develop these skills that you need so that you can maintain this balance.
Great point. And Adam, what would you add?
Well, I mean, in medical training, it's tough to dissect duty hour limitations from discussions of work-life balance, and they are distinct. I think it's important to mention that trainees now, medical trainees, know we have it better than the generations that came before us in terms of the amount of time that's spent in the hospital. We appreciate that, and I think we also, despite horror stories that you may hear about residents leaving as soon as their 80 hours over 4 weeks are up, the vast majority of us, I think, hope for a semblance of work-life balance, but expect that we're going to spend the time that's needed to take care of the patients in front of us and make sure they're safe and make sure that the teams that are coming on to assume care for them have what they need to provide the best possible care. I think there's another dimension of balance that I'd really like to emphasize here, which is the reward that we get from the practice that we have, the practice of medicine that we're doing. That matters too. Burnout is real, and there are all sorts of levels of the grind of medicine that can take the creativity and take the enthusiasm and ingenuity out of daily practice. And that's, I think, where a lot of the reward and balance and feeling of fulfillment from what we do is lost. And
So fulfillment is a good place for us to summarize
Yeah.
and say that you've done a beautiful job really commenting this afternoon, and I know that Phil and I are both so pleased that you joined us. Thank you.
We on? Let me add my thanks as well. You may be newly minted, but you are deeply insightful, and you've certainly shared with us what you're hoping to see happen in the future, perhaps what's not happening now, but even more importantly, your willingness to be leaders as we move forward.